Thanks so much, Abigail, and a very warm welcome to each one of you again to our webinar. The webinars, as you know, are for the month of September, used as an educational and awareness tool to acquaint people with some of the specialities and subspecialties that we have in the care of people living with dementia and their carers. And we're putting these onto, recording them and putting them onto our YouTube channel to serve as a further reference for people who possibly didn't get the opportunity to see them, and maybe even for each of us to refer back to them just to understand. So just a very brief welcome to Professor Niehaus, a very warm welcome, Professor Niehaus.
Thanks, Karen.
So Professor Niehaus is a subspecialist in is a subspecialist in geriatric psychiatry, and he leads a psychogeriatric unit at Stickland Hospital. And I am almost correct in saying that it is still the only one psychogeriatric unit within South Africa. He is a senior lecturer at the Department of Psychiatry at the University of Stellenbosch, has a long-standing interest in research, and certainly has been a friend of DementiaSA when we've needed help, and also is very passionate about the rights of the elderly and treating the elderly with respect. So very, very warm welcome, Professor Niehaus. We're very lucky to and very honored to have you on our webinar today.
Thank you, Karen, for the invite. It's a pleasure being here.
So, Professor Niehaus, if we can just maybe start really with the basics in trying to understand what the various, what are the various subspecialties in each of, the people that are making diagnosis of people living with dementia. We have a neurologist, we have a psychiatrist, we have a geriatric psychiatrist, a geriatrician. Would you just explain to us very briefly what the various subspecialties are and what role they play?
Yeah, Karen, there's quite a bit of overlap between the different specialities, and I think that's the first thing that we need to understand. So your general psychiatrist gets training in geriatric psychiatry for a period of 3 months during their training. Then your subspecialist psychogeriatric psychiatrist is an additional 2-year training that also requires additional research projects, etc. And then you get registered with the Health Professionals Council as a geriatric psychiatrist. So I think it's in terms of they've got more experience and specifically focus in that field. Neurologist focuses on the neurological basis of dementia. They don't necessarily spend that much time during their training in terms of the psychosocial management of dementia care. And then your general practitioner gets training during their student internship, a period of about 7 weeks in psychiatry. So I think in the end it boils down to time periods, but each of these play, according to me, a symbiotic and crucial role. So for me, the GP, general practitioner, should still be the team leader. Majority of the medical aides also prefer that they are the team leader and that referrals actually is done by them so that they collate all the information. I often find in clinical practice that you've got 2 or 3, you've got a neurologist, you've got a psychiatrist involved and a GP, and we don't always know what the other one is doing. I think traditionally medical specialists, including myself, are not that good in communicating with our colleagues. And I think it's therefore the GP plays a critical role. Psychiatrists and neurologists, I value the role of neurologists in the diagnosis and management of dementia. And very specifically, some of the subtypes of dementia I think the neurologist can play a much more critical role than the psychiatrist, and there I view the psychiatrist as complementary to the neurologist services. And examples would be something like progressive supranuclear palsy, where swallowing difficulties, movement difficulties occur relatively early. Parkinson's disease with dementia is another example where I think the neurologist plays the primary diagnostic and treatment role, and where the psychiatrist would be complementary to it. I think if you are planning to have your loved one seen by a specialist, is to take in consideration that it should be a team approach. And I would try and find a neurologist or a psychiatrist via your GP that usually works as a team. I think that that's the most useful approach.
Thank you so much for that overview, Professor. I think that that is, for a family starting out, or even a family already quite into caring for a loved one with dementia, it's good to know what each person or each speciality plays. And, you know, I think it is also about creating the team approach where there's referrals, constant understanding, especially when it comes to tweaking some of the medications, etc. And then also the geriatrician, if there is any predisposed conditions that the person already has that relate to aging. So thanks very much for that. That's very useful.
Yeah, I think what I can maybe highlight here is that it also has to do with the availability of resources. So we've got very limited number of geriatricians. And I think the geriatricians are always the first stop for me if you do have the access to that resource. But for example, in the northern suburbs, we've got one geriatrician. In southern suburbs, I think there's like 3 or 4 geriatricians. So there's a limit to what they can actually manage. And I think that's why the psychiatrists and the neurologists take on part of that duty. But a geriatrician is absolutely critical in the management.
Fantastic. So then my question then is just in terms of frequency of visits, how often should medications be reviewed and how often should the patient be assessed?
That depends on the patient and the setting. So if there are a lot of medical comorbidities, the frequency of assessment will depend on the frequency of which the medical comorbidities need to be reassessed. Secondly, if it's purely down to the monitoring of the dementia, management and treatment, then I think it depends on where you are in the course of management. If it's during the initial diagnosis process, I find it often very difficult to get away without seeing the patient and the family. And it usually takes about 2 to 3 visits in that first month or 2 to get a whole treatment plan and the process going. And after that, it depends on what medications one starts off, and also if there's any associated symptoms of dementia. That includes your depression, anxiety, maybe behavioral difficulties, because that will also determine. I think the maximum period that you should go without a reassessment is 6 months. I find it very difficult to see how it would be possible to do a proper dementia care without reassessing the individual every 6 months. It's a progressive, it's a changing illness over time. And I think one needs to monitor that very closely.
Well, thank you for that, Professor Niehaus. Just in terms, seeing as though we still are in the middle of a world pandemic with COVID-19, even though South Africa's in level 1 of lockdown, there's a question that has come, and there's been many reports about loneliness and about feeling sad, depression, etc., that where we feel and we find that many elderly have been very severely affected. So the one question is, I have a friend who turned 80 years old during COVID and was fully functional in all her activities of daily living and driving as well. She lived on her own. She lives on her own in an independent facility with no care attached. And during COVID-19 isolation, it heightened her levels of anxiety and paranoia of passing on the virus and receiving the virus, to the extent that she is now paralyzed with fear, unable to take part in life and fully perform her daily activities. She was seen by a psychiatrist since and scored 30 out of 30 on the MMSE. Social work report has indicated that she's aware of her paranoia, doesn't know why she's feeling like this, and her memory is sound. So she is on some medications, alazapram, 5 milligrams, she takes half at night, allopurinol, 100 milligrams, Xylof, 20 milligrams, and Aleva 8. Macrodantin, 50 milligrams, warfarin. She's unfortunately taken her antidepressant haphazardly. And the question here is, will the anxieties, the fear, the paranoia eventually reduce to the level where she will be able to take part in her daily routines? And would there be anything else one could try? By nature, she has been a worrier. Financially, she is unable to afford carers. And the next step would be a care facility. At this point, I feel she would deteriorate rapidly in those conditions. So,
I think there's a few aspects. So let's start first off with loneliness. Now, loneliness has got a biological basis. And what COVID-19 and the regulations has done is to put loneliness forward as one of the major contributing factors to changes in mental health and mental health status. So if you look at loneliness per se, loneliness is associated with an impaired immune system response. Some of the research they did on students was when they gave them the flu vaccine and they looked at how many friends they were. Those that had less friends, and that is 12 to 13 and less friends, they had a poorer immune response than students with 14 or more friends. They also found that in the Framingham Heart study that looked at older adults and heart disease, where loneliness was associated with an increased risk of mortality, lower immune response, and increased symptoms of psychiatric illness. And what constitutes loneliness? Well, loneliness constitutes how many social contacts you have, your own experience of feeling lonely, and then also how well you're embedded in your social circle. Now, if we just look at the COVID period, for you to make a new friend takes about 200 hours of face-to-face contact in general. So in COVID, that has been severely restricted, the face-to-face contact that was possible. The second thing is that once you have a friend, within 3 months, you lose the emotional connectivity to that friend. It is a direct line between less contact and losing that friendship. The friendship can be rekindled, but the emotional advantages is lost within those first 3 months. So we can see that just in COVID, we should have lost a part of the friend circle, and that circle supports us in terms of endorphins, how we feel. It curbs anxiety. The next thing that's important is with COVID came the wearing of masks. We are highly dependent on our visual skills to form relationships. So you value your relationships based on the facial expression of the individual that you're looking at. And facial expression divides the face into two, the upper and the lower part. With COVID, we are unable to see what's happening in the lower part of individuals' faces. Therefore, we cannot communicate effectively, and it's more difficult to form friendship and bonds, and also to reestablish or rekindle those. So I think it's a double whammy. We've got less social contact, And when we do have social contact, we are restricted in how we can perceive the body language or the facial expression of the individuals. So it's not surprising that we're seeing psychiatric or psychological symptoms emerge during and after the COVID pandemic. If we think about this specific case, I think the approach was correct. First of all, try and establish whether there is a physical or psychiatric illness underlying this. Then try and optimize the treatment. Now, if we think about possible alternatives that's available here is one, let me just back step one. The fact that you've got a mini mental score of 30 out of 30 does not constitute the absence of cognitive changes. And for me, that's an important concept. So I would be interested in knowing whether this individual had a high IQ, a high level of functioning, how many degrees or studies did she have, how much cognitive stimulation during her life. Because individuals with high cognitive reserves can still score 30 out of 30 on their mini mental, but there can already be cognitive changes or brain changes. Plus, it's also important to realize that memory per se, and we know that memory per se is not the only constituent symptom that we look for in dementia, because we also start thinking about frontotemporal, early frontotemporal changes, because frontotemporal changes will have a change in your behavior, but you won't necessarily pick up any memory changes. So my advice would be to explore a little bit more what this lady's cognitive reserves are, and maybe do a more detailed neurocognitive assessment to get you some idea of whether there's maybe frontal temporal lobe changes. Because remember, isolation or loneliness is a risk factor for the development of dementia per se, and that's been reiterated now in the latest Lancet report as well. Yeah. Then if we move over to the treatment, the haphazard taking of medication, there's one red flag there, and that's we must realize that before dementia is diagnosed, some of the earliest changes that occur is one, your medication adherence deteriorate, you've got less driving ability, and your social connectiveness changes. And I would explore that a little bit more, and also financial management. I'd explore those aspects a little bit further. The second thing is haphazard taking of antidepressants has got more a detrimental effect than a positive effect. So I usually advise people, if you're going to take your antidepressant haphazardly, rather not take it. Specifically if it's a so-called short half-life antidepressant, something that stays in your body for a short time. The only one that stays in your body for a long time is fluoxetine. And if you're not on fluoxetine, you're supposed to take your medication each and every day. Otherwise, you can get periods of increased anxiety, increased emotionality on the days that you're not taking it. Then, in terms of other options available, of course, is psychotherapy. We underestimate the value of psychotherapy in older adults. For some or other reason, we believe that once we turn 60, magically we can't change our behavioral patterns, we can't address our anxiety on a psychological basis. And I think it's important that one asks the opinion of a psychologist in this case to see if the psychologist can, for example, use cognitive behavioral therapy, which is a very effective method for curtailing or helping with anxiety. Will it normalize us again? Well, it depends on the things that we've just said. One, can you effectively manage it with either medication or psychological therapy? Secondly, is there maybe an underlying cognitive changes that is keeping the anxiety going at this stage? And I think that's as far as one can comment on this case, not having seen the patient.
Fantastic, Professor Niehaus. Some of those aspects are very important even to those who take care of somebody living with dementia, irrespective of the fact. I think even just when it comes to COVID-19 and how, a carer caring for somebody with dementia in isolation, it really has brought home just, you know, what it is in terms of our general mental health, and how we need to possibly even at times, you know, possibly go to a psychotherapist just for 1 or 2 or 3 sessions, just to be able to offload and to understand that they are that mental health is certainly, you know, a priority, whether you have a predisposed condition or being treated for a condition. It's important that you know, that one addresses that mental health aspect.
Yeah, and I'm just going to interrupt you, sorry. Yeah, well, the other thing that's interesting about the COVID pandemic is that your mental health status also seems to depend on the mental health status of your closest friends. So again, the Framingham Heart study showed that if you have a friend that is happy, that you increases your own chances of being happy. It sounds, you know, as if this is the way it should be, but we never actually realized that. Plus, if your friend stays within 1.6 kilometers from you, those friends closer to you, their mental health status is mirrored by your own. So if you are caring for someone and that person's mental status over the last few months has been depressed or anxious, that mirroring behavior can also impact on you as the carer. I think it's very important that we remember that we have got these what we call mirror neurons, which means that we mirror the behavior of the people that we have the most contact with.
Right, absolutely. And I think that's also where, you know, constantly watching the news or having the news on in the background can also be quite detrimental, particularly when at the height of the pandemic, when there was so much fear that was pumped into everybody about all of it. And, you know, there's no what do they call the ventilators, there's no this, there's no that. And I think that sort of fuels the fear that people had about the you know, about the virus. So I want to move on to a question which was also asked. I'd like to know how my father can be included in a company when having a gathering. He cannot take part in conversation. It's almost like he isolates himself and not showing interest in talks. He would not sit up and he ends up leaving the space. I know that he does not like crowds, so I don't pressurize him to be part, but other people outside the situation do not understand and would probably think that she keeps him away. Interesting question.
Yes, Karen, I think this is a very difficult question to answer, and I often get it in conversations with my patients as well. And I think what we need to take in consideration is the patient's or the person's life story. For me, the life story is still the most important thing. So if you know that mom or dad never liked crowds, my feeling would be, why would we now insist that they start liking social interactions and crowds? We get what we call in life your happy loners, and your happy loners are people that generally tend to be happy being alone. I think in our social structure or environment, we expect everyone to be extroverts and to join in conversations. But I think it's about respecting the fact that some people are not extroverts, that some people do prefer to be alone. My advice to families are usually to be guided by the life story of that individual, and then to accept that this individual will find social interactions stressful. Even extroverts, during the process of the changes associated with dementia, social interaction becomes very stressful because of the cognitive reserves and abilities that's needed for social interaction. Because social interaction depends on non-verbal and verbal behavior, and picking up these cues in different individuals, compiling these cues, Then taking these cues and incorporating them with your own experience, and then from that combination of factors, you can then respond. So if your cognitive reserves are limited and your social cues are restricted either by eyesight or by slight impairment in hearing, that complicates it even more for you. So I usually say, once you see that mum or dad is tired and they leave the conversation, let them leave. I think the important thing is that other people need to respect the personal space, preferences, and the illness of the individual suffering from dementia. And it's often our own perceptions of what we think would be socially acceptable that will determine our behavior in the circumstances. So I would often advise families to allow their loved one to leave the conversation once they become tired or agitated.
Right, that's great advice, because I think very often caregivers are the ones that are the most criticized within family settings for, not allowing a person to be agitated, etc., because very few people actually understand what it really is like to care for somebody with dementia. And caregivers, I found in my family situation, were usually always the ones that were the most criticized. So very, very good answer. Thank you so much for that. That's great. There is another question then that pertains to, do delusions in dementia relate to real life in any way? I know my mother feared being attacked and had a close friend, two close friends actually, that were killed. So her persistent delusion is that we are going to be shot every night. And she also loved crowds and parties, and she often sees dancing crowds. So do previous delusions also in dementia relate to anybody's real life experience in any way?
Yeah, that's a very interesting question, and we've often debated it. And my personal opinion about it is yes, it reflects. And I think the reason for that being delusions, as we know, is a fixed false belief. That's the definition of it. But it's also down to your life experiences and how these life experiences impacted on the memory and what memory is stored. And that memory is often re-emerges in the forms of very specific types of delusions. So we often find that delusions would correlate with the life story of the individual. So no, it's not uncommon to find that.
Right, that's very, very interesting. And I think that also then pertains to, when somebody does go into a residential care facility, that all of that is written up as part of their life history. You mentioned life history earlier on, and I think we as carers, we underestimate the importance of telling people about that, how our loved ones react to certain things, what their life experiences was, what their profession was during their life, etc., etc. So what their interests were. So I think that, those kinds of things are very important because, as behavior is really pivotal in verbal and non-verbal, one can, that can help them manage, a care facility manage the person that much better and with a lot more focus and understanding.
Yes, Karen, if I can maybe add to that, there's very specific neurons in the body and it's linked to your hair follicles. And depending on the stroke rate, the tempo at which you strike, you should stroke someone at about 2.5 centimeters per second, which basically boils down to a slow stroke, which is the same as grooming behavior in animals. If you do the slow stroking behavior over the skin, That triggers very specific areas in the brain that's associated with social cohesion and releases endorphins. But, and this is always the important thing, it also depends on your life history, because not everyone will respond positive to this stroking, slow stroking behavior or grooming behavior. And for me, that's critical, because you often teach people human contact is absolutely critical, and you need to do this and you need to do that. But there's always the important caveat, if the person naturally likes this type of behavior.
Right, right. And therein lies the secret of it all.
Indeed.
Professor Niehaus, working at Stickland Hospital, there have been a number of questions that have come in regarding shortages of medications at some of the clinics, patients not getting their full scripts, or medications being changed. What is the situation? Have you maybe got an inside scoop from Stickland Hospital, maybe in terms of how these medications are distributed? What can one do about these shortages? Because it appears that at clinic level, there are people that are either changing and substituting medications, and in some cases referring to the memory clinics at Groote Schuur Hospital, which is fine. But the point is that people with dementia are very sensitive to these medications. So a sudden change in them is really not a good indicator at all. What can you give in terms of how you're experiencing medications even at Stickland?
I think what I maybe is give an overview of where we stand in the state sector at this stage. So Stickland Hospital is currently still the only psychogeriatric referral unit. And this is for the whole Western Cape and Southern Cape. So people get referred to a secondary hospital, and this secondary hospital can be Hottentots Holland, it can be G22 at Groote Schuur, it can be Victoria, any of those hospitals, and there they then end up on a waiting list to get to Stickland Hospital. Stickland Hospital's got a limited number of beds. We've had a recent increase during the COVID pandemic. We're now at 70 odd acute beds, but we still have a waiting list that can approach up to 9 weeks to get a bed. Part of the reason why it's such a long waiting list is that at this stage, 3/4 of the individuals in my wards have got placement issues. And although they are psychiatrically and medically stabilized, we cannot place them because we don't have placement options. This, of course, means that we have to run an acute system on 25% of our available beds, and therefore you get a very long waiting list, which means that if you refer your loved one into a secondary hospital, they're going to stay in that hospital for an extended period. Now, the secondary hospitals are under immense bed pressure. While we at Stickland Hospital can still say we cannot discharge older adults in line with the Elder Care Act, we need to safeguard and make sure that there's the necessary exit plan. The secondary hospitals do not have that luxury. So the secondary hospitals need to sometimes discharge older adults even before they can reach Stickland Hospital, purely because of bed pressure and just the unavailability of bed resources. So that's the first thing to understand. The second thing in terms of the medication issues is that it is a statewide issue. At Stickland Hospital, we have in the recent 6 months had medication outages of different medications. I think one of the questions referred to olanzapine, that for some stage was not available. Then we had to use quetiapine, then quetiapine became unavailable, then we had to use olanzapine, then risperidone was unavailable, then haloperidol was unavailable. So there's on a short-term notice, we have to change medications. It is not ideal. I don't like it. And we try and avoid it as far as possible. But the reality out there is that there's something to do with the provisions at this stage of medications. Is a serious issue in the state sector. And I think the important thing is that we have pressure from organizations such as yourselves to try and motivate for a more continuous availability of medications at these different hospitals. So what I've done is, in my patients, I've given them a private script as well as the state script. So that if they have got financial resources, that they could try and buy some of the products at the private pharmacies until one can get support from the state sector again. But except for that, there's nothing else one can do at this stage. We don't get long warnings. It's literally a week or two, then we know that something's not going to be available. I do not think this is the end of it. I think this is going to be a continuous issue for the next few years. And except for making sure that you get a private script from your local clinic just to cover you, there's very, very little that you can do.
Right. Wow. That's, you know, the story that was in the Daily Maverick also refers to stock shortages around the world, particularly as some of the big pharma producing factories are in countries like India and Sri Lanka, and it's also to get medications shipped out of those countries into countries that that obviously need the stock. So it's a very, very difficult one. Is there anything that DementiaSA can do, you know, to assist other than writing to the two ministers, the National Minister of Health and the Minister of Health in the Western Cape? Anything else that we can do?
I think that's already wonderful if you can do that. And then the second thing I think is to maybe just raise the awareness that it is possible for you to get a private duplicate script at your clinic level as well. And if you do have the financial resources to try and buy a generic product or the cheapest product available, so you can try and avoid these sudden medication changes that's now occurred. And Karen, I always think one should always measure oneself against other countries as well. I also work in Namibia from time to time, and in Namibia there's been even more severe shortages. For some period we didn't have any lithium in the country. Now, lithium is one of the most important and critical management tools for bipolar disorder, and without that, people relapse immediately. So I don't think it's something just specific to South Africa. This has been a global phenomenon, and I think developing countries has been hit the hardest with the shortages.
Right. Okay. Well, we'll certainly try from our side, but good advice there to get a private script as well from source, so that you can go to a private pharmacy and get if need be. It almost seems a little bit strange that you can get it in the private sector, but it's not available in the state sector. But anyway, be that as it may. There is another question that's come through on the chat. How should I monitor mom's driving? She's 86, she's diagnosed with Alzheimer's dementia, has no frontal lobe symptoms, has a relatively good level of cognitive behavior, has poor short and medium-term memory. During COVID, she only drove 1 kilometer to visit her mother-in-law, this lady's mother-in-law, who lives alone, and so she's asking under normal conditions, how should she monitor her mom's driving? I know driving is a very, very, very big issue.
Yes. On a lighter note, the moment I address driving in my practice, that's usually the last time I see the patient. But yeah, driving is a very critical factor. And Kathleen Ross, one of our geriatricians in Cape Town, actually wrote a brilliant paper on it a few years ago. But in essence, what you're looking for is the so-called red flags. So the first red flag is a mini mental examination score of 20 or below. That is a major red flag. So one can always ask mum or the physician what the mini mental score is. That's the first important one to look at. Then after that, you need to look at both dementia-related features as well as physical-related features. So physical-related features is things like, do you still have enough upper and lower body strength to drive? Secondly, is your vision okay, and is the hearing okay? And one often forgets to look at these physical factors. That's very, very critical. Then if you look at the dementia-related factors, the one thing that we do is we look at, first of all, are there a reduction in the overall kilometers that mum is traveling? The moment that there's a reduction, it shows that the person usually has become less confident in their own driving. Secondly, is if the co-driver or co-occupant in the car starts feeling nervous and feels that the driving is becoming more dangerous. And this is often a very difficult thing, because I often find that it is a couple and one of the couple is dependent on the other one to be able to drive. Otherwise, their dependence per se is impacted. So they're often not disclosed that it's very nerve-wracking driving with the individual. Third thing, if any accident occur, how little, that's another red flag. And what I often do is my office looks out on the parking area of my practice. And I often quickly just check the car. So there's a few things I check. I check the parking, is it parked correctly? Secondly, I check when the parking is done, whether the co-driver actually gets out of the car and tells the driver how to maneuver into the parking space. And then I look for any bumps or scrapes around the car, because lots of these little bumps and scrapes is usually indicative that there's something brewing. Then if a number of these red flags occur, then one can do a formal driving assessment if one wants to, and that can be done at different sites nowadays. I know the Faculty of Medicine at Stellenbosch has got a driving assessment. I know one or two of the private occupational therapists also have driving assessments, and there's now new batteries that they can use, the occupational therapist, that gives you a standard of the ability of driving. And they then hand out a report, and this report is very useful. Okay, so if there's one or two of the red flags and you think it's still safe for mum to drive, then there's a few rules that I usually apply. One, do not drive at night. Our light perception changes as we get older. So in the evening, it will appear as if cars are driving much faster than they actually are. And that's why you tend to slow down when you drive at night as you get older. And then secondly, do not drive during peak times. Only drive in areas that you've previously driven, and if at all possible, always have a buddy with you in the car. I often explain to people South Africa is dangerous, just as many other countries are dangerous. We've seen a spike of attacks on older individuals in the last 2 or 3 months, and I think one needs to be safe from that perspective as well. And then from a family perspective, I usually advise that one installs a tracker system in the car, to which you as the family members got access, so that if anything goes wrong, you are able to pinpoint where mum is at that specific stage.
Right, that's all very interesting, and especially all the dings on the car. I mean, we've seen quite a few people living with dementia who have far more than just a few dings, and actually cause very serious accidents, which I must just add, the insurance does not pay out if a diagnosis of dementia has already been made. So that's one thing to be aware of as well for family members. So
I always pose this to family. I would say, if mum's independence versus the life of her grandchild. So if she's in an accident, the grandchild runs in front of the car and you've got slow responses and you kill your grandchild, was it worth the independence of going to the shop twice a week? And for me, that's the critical thing. And yes, I understand the most common response I always get is, I've been driving for 57 years, I've never made an accident. Yes, that's true, but tomorrow is a different day. And the problem is when you have that accident that kills a child, that's the accident that you'll always remember. And that's when things become an issue. And I think South Africa has changed to such an extent where, for example, Uber has got a service specifically for disabled or older adults that you can ask for. You have local organizations that's got the ability to take you to the shops, bring you back. They can even accompany you. And yes, I do understand it's slightly more expensive, but as you've just rightly pointed out, if you are in a car accident and the insurance doesn't pay out, you could have had Uber trips for 50 years for the same cost of that third-party claim that you're going to be liable for.
Right, 100%. So I think it's always to put it into the context of, you know, if this had to happen to our family, and it was known at the time that the person did have dementia, how responsible is that, allowing her to drive? So I think you're quite right, and thank you for that comprehensive answer. It would be great to get the resources of those occupational therapists who do the battery of tests that we can pass them on and post them for people. So that would be great. Thank you. There is one question here then, if it's, I recently moved my mom from frail care during lockdown to come and stay with her at home. She's aware of her habits and she's noticed that she's very vocal and groans and mumbles a lot when falling asleep day or night. She also has audible conversations with, just hold on 2 seconds. She has audible conversations when asleep in the middle of the night. Her meds include altroxin, Zytomil, Alzam. She was prescribed Rivotril at night for being active while sleeping at night. Her specialist thought that she may have a Lewy body dementia. The Rivotril replaced her sleeping tablet. She then became rather anxious and couldn't sleep at night and was given Arizophie. Early in the evenings, the doctor said to watch for any side effects of the body rigidity due to the possible Lewy body dementia. No side effect appeared evident, so they're not sure what type of dementia she has. Her night meds are Alzam and Rivotril. After some months, she started becoming agitated with paranoia, and her doctor prescribed Dopacol. Since staying with me, her agitation and paranoia have reduced, so we stopped the Dopacol. Are these meds possibly causing her extreme daytime tiredness? And could they be causing all the noisy vocalizations while sleeping?
Okay, so I think the first thing is to look at diffuse Lewy body. So diffuse Lewy body as a type of dementia. There's the so-called core features. It's changed over the last 2 or 3 years, but some of the core features still include that people with diffuse Lewy body has got what we call REM sleep behavior changes. So your REM sleep is the period where your body actually is active while you are asleep. Previously, it was believed this is the only period that you actually have dreams, but now we know you can dream in other stages. But this is the period where you have sleepwalking, talking in your sleep, all of those type of behavior, because the muscles become active, even though the brain is asleep. And with diffuse Lewy body, this is what we find, these REM sleep behavior changes. where it's a restless sleep with different types of behaviors that can occur. And that's most likely why the treating physician gave the clonazepam or Rivotril. It's one of the treatment options you have to try and help with the REM sleep behavior. Diffuse Lewy body is also associated with an increased risk of psychosis, so hearing things, seeing things, believing things that's not true. Which is also one of the symptoms that you've highlighted here. And when you use medications such as Aristophane, which is aripiprazole, it's one of the antipsychotics, but it's one associated with the least chance of sedation. If you look at Dopacol on the other hand, which is quetiapine, that is a more sedating antipsychotic. And often it's a balance between managing the psychosis versus either sedating or non-sedating medications. If the symptoms has reduced, it's fine. Then you can just carry on with your care without the use of the Dopacol. It's important that quetiapine or Aristophane does not cure the hallucinations, it controls the hallucinations. But if you can manage the individual without the need for those medications, so be it, then you do it. It's always better to have less medication than more medication. For me, the most important thing is if there are still hallucinations or delusions present that the individual finds threatening or emotionally upsetting, then I tend to use the medication, because for me it's still about the quality of life of the person suffering from dementia. And if we can maintain the quality of life, that's important. And quality of life means as little as possible anxiety, as good as possible mood, and as little as possible psychosis. In terms of the general movements, remember when you fall asleep, you go through the first phase of sleep. And often in that phase, you can also naturally get movements. That can be knee jerking or other movements that can occur. And you often, it happens that you can wake yourself again within that first few minutes due to these movements. This is also the periods that's associated with normally having hallucinations. So even people without a psychotic illness can have these so-called hypnagogic or hypnopompic hallucinations. Those are hallucinations that can naturally occur when you fall asleep or just when you wake up. One of the other hypnopompic, or when you wake up, hallucinations is a so-called sleep paralysis, where they wake up but you just can't move. So your brain is awake but your body is not responding. And that can also occur naturally, occurs more in some families, kind of an inherited pattern that's present. So to summarize in this case, the features are suggestive of a diffuse Lewy body. On what information that's available to us, it seems like the doctor is following a reasonable approach, has warned you about the most common side effects that can occur, and that if you can manage mum with the quetiapine, which is the more sedating one, specifically if you complain that she's sedated the next day, so much the better. You may consider to maybe use one of the two benzodiazepines at night, either Alzheimer or Rivotril, because both of them are benzodiazepines. And I often prefer to use one of the two.
Fantastic, Professor. I think we're going to take one more of the WhatsApp chat questions, and then if you would like to perhaps approach one of the questions on the chat, we'll open that up. I'm very conscious too of Professor Niehaus's time. What happens in the mind of a person with dementia when they can no longer remember the connection between a daughter's name and the actual person? So somebody seeing a daughter but calling the daughter possibly a sister or somebody else's name. What happens in that particular, in that person's mind is the question.
So it boils down to the fact that our brains are wired differently to detect different things. So we've got specific areas that detect emotions in other people. Like, for example, the amygdala detects fear. But then we also have the so-called fusiform gyrus, which is an area kind of in the middle of the brain. This is probably the easiest on this side. That's responsible for the identity of faces. You've got a different area that is responsible for identifying buildings or cars or other inanimate objects. So when this fusiform gyrus, which plays a role in the identification of faces, when it starts becoming affected by the dementia, you are unable to connect a name and a face anymore. And that's where the confusion usually then starts. Now, your emotional memory helps in terms of it, because emotional memory traces are usually conserved slightly better. So mom and dad, they were involved in raising you. There's a strong emotional connection, so their memories also stays relatively longer. So yes, it's the deterioration of very specific areas that leads to this disconnect between the face and the person. So even though you, for example, know the name of your child, the name and the face is not connected anymore. And that's where the disconnect then happens.
Right, right. That particular part of dementia or the progression of the illness actually does cause so much trauma in family members. So it's good to have an understanding that it really is something that that happens as a part of the progression of the illness, and there is a physiological explanation for it.
Correct. It is purely a physiological basis.
Fantastic. Thank you so much, Professor. I'm going to hand over to Abigail, who's going to go through some of the questions, or one more question, one last question. But just from my side, Professor Niehaus, you've been amazing, as always, and DementiaSA is enormously grateful for your contribution. Thank you.
I can't thank you very much. It's always a pleasure sharing a platform with you. I think DementiaSA is doing an absolutely stellar job, and I think I am eternally grateful for everything you do as an organization, because I think without this organization and the support that you're giving the individuals, we would be in dire straits. And I really appreciate everyone at DementiaSA for all the effort that you put into the care of dementia.
Thank you so much, Professor. It means a lot coming from yourself at Stikland. Thank you. Thank you.
Thank you.
Abigail, over to you.
Thank you so much, Professor. I see the time is 1 o'clock. And so I wanted to, I think my suggestion is if people have questions, what they should do is possibly email myself and I pass them along, or they WhatsApp them at the support group. And just a huge thank you, and to remind everyone who's here that on Thursdays at 1 p.m. we host a virtual support group, and everyone is welcome. If you'd like to join, please put your number in the chat section of this call, and we'll happily add you to that. Professor, are you okay? We'll share your practice's details with everybody, if that's okay.
That's okay, Abigail. I think yeah, they can contact me via Stikland's switchboard as well if they've got specific questions, and I'll give you the number and you can put it on later. It's 940 4400. So 940 4400. That's the one.
Thank you so much, and just a huge thank you to you again.